This patient sustained orbital trauma 2 weeks prior to these photos being taken. The restriction of upgaze and downgaze strongly suggest inferior rectus entrapment. The CT scan confirms that a trapdoor fracture has occurred, in which a hinged fragment of the floor has been momentarily displaced to allow inferior herniation of orbital contents, and the hinged fragment returned to near normal position. This fracture could easily be missed, highlighting the importance of clinical examination, although the presence of orbital contents in the maxillary sinus also confirmed the fracture. The inferior orbital floor is being accessed through a swinging eyelid incision. This conjunctival approach with just a small lateral skin incision has the advantage of minimal or no skin scarring. However, the alternative subciliary or lower lid skin crease approaches can also provide good access and minimal scarring if carefully repaired. All approaches can result in postoperative entropion, ectropion or scarring if the lower lid anatomy is not respected and care taken during surgery and repair. The swinging lower lid eyelid incision is discussed in detail in another video on www.eyesurgeryvideos.net. But, briefly, a small lateral canthotomy incision is made, followed by lateral canthal tendon cantholysis. Straight, sharp scissors are spread just inferior to the tendon to create a small prolapse of orbital fat. The scissors are then passed into this pocket and medially posterior to the retractors. The conjunctiva and lower lid retractors are incised a few millimeters inferior to the tarsal plate with a hot wire or cut with scissors. The inferior orbital rim is brought into view by retracting the lower lid anteriorly and inferiorly with a Damar retractor, and using a malleable retractor to retract and protect the globe. The tissues that are now stretched over the orbital rim and the periosteum are incised, here being done with a Colorado monopolar on the cutting setting. Care should be taken medially as the inferior oblique origin is a few millimeters behind the medial end of the inferior orbital rim. A periosteal elevator is used to separate and raise the periosteum of the orbital floor to provide access to the floor fracture. The periosteum is very loosely attached and the plane easily dissected, apart from the strong adherence at the rim. Trapdoor fractures typically occur in the soft, malleable bone of children. These fractures can usually be depressed to allow the herniated tissue to be released and the floor will return to its normal position, and a floor implant may not be necessary. However, the patient in this video is a young adult and the fracture occurred 2 weeks previously, allowing fibrosis and adhesions to develop. Therefore, the herniated tissue is more challenging to release and the bone requires more manipulation to facilitate it. The orbital floor is explored by passing malleable retractors hand over hand. The herniated tissue and the trapdoor fracture are located. The inferior orbital fissure can also be located. The infraorbital nerve should be visualized, and consideration also be given as to whether it has also been entrapped. The Freers dissector, with and without a suction attachment, a Roton-type dissecting hook, and a squint hook can all be used to assist with gradually easing the herniated tissue out of the defect and breaking down any adhesions. Dry neuropaddies can be used to control hemostasis and keep the field dry. In this case, the fracture is in the lateral floor and the infraorbital nerve not involved. A forced duction test is conducted on multiple occasions throughout the procedure to confirm the increasingly unimpeded motility of the globe as the tissues are released. Complete release of herniated tissue is confirmed when bone is seen throughout the periphery of the defect. It is particularly important to assess and confirm an adequate posterior edge, as the implant will rest on this, and if it is not present or adequately exposed, the implant will either not be stable or will be pushed forward. If no posterior edge is present, The implant will need to be secured anteriorly with screws to provide a cantilever effect. Good hemostasis is very important, as compartment syndrome with subsequent visual loss is possible, although extremely rare. Hemostasis is achieved before continuing to prepare and place the implant. An orbital floor implant is often not required in a child when the floor returns to its normal position. However, in this young adult, an implant is being used in view of the residual defect and less elastic bone. Various materials can be used to cover the defect. They can be divided into autologous materials, usually bone or cartilage, and synthetic materials, which are either absorbable or non-absorbable. Non-absorbable materials, such as porous polyethylene, titanium, silastic sheeting, and mixtures of these, are more commonly used. These synthetic materials are increasingly widely used because of their ease and speed of use, the avoidance of donor site morbidity, and the excellent long-term reported results, although they probably have slightly higher infection and extrusion rates than autologous materials. Nevertheless, the complication rates are extremely low. This one is a porous polyethylene-covered titanium implant. This has some of the advantages of both substances in providing the pliability of titanium, but with the smooth surfaces of porous polyethylene to lessen the risk of adherence of orbital tissues and avoid the sharp edges of titanium when the implant is cut. It also has screw holes, although these are not being used in this case as the implant will be firmly held in position by the globe. The integration of the implant can be both an advantage and disadvantage, as it is thought that it reduces extrusion but can make it more difficult to remove if necessary. However, most implants have very low complication and extrusion rates, so generally one type is not universally favoured, and the choice can be surgeon and patient specific. The sizing and positioning of the implant is much more important than the material selected. A template can be made or the size estimated. The retractors are used to carefully and thoroughly lift all of the orbital contents away from the defect and the implant slid into position. A forced duction test is repeated to confirm that the tissues are not trapped. The implant is just behind the rim and there is no pressure pushing it anteriorly. A drain can be placed, although is not usually necessary if hemostasis has been achieved. Less is probably more with closure. The periosteum can be closed over the orbital rim. This may provide an additional barrier to extrusion, although extrusion tends to occur later when the defect would have healed irrespective of whether sutures have been used, and is probably more related to poor placement or an excessively large implant. The tarsal conjunctiva is repaired with a 7/0 vicryl suture. The retractors are not separately repaired. Overzealous or crude retractor repair probably increases the likelihood of entropion. The lateral canthus is reformed, orbicularis closed, and the skin closed. If eye padding is used, the vision and pupils must be checked 1 to 2 hours post-operatively to ensure a retrobulbar hemorrhage is not developing and causing optic neuropathy.